All right, so now we are going to move on to post-op care. We covered pre-op care, what to do before the surgery, and then now we're going to talk about post-op care, what we do after the surgery. So the post-op period, sorry, the my bad. Obviously begins immediately after the surgery. The post-anesthesia care unit, the PACU or recovery room, is usually right next to the OR. So you can just take them right from the OR there, and so to the recovery room, and then the anesthesiologist is right there. The surgeon is there, and staff in case they need to go and do anything, something happens. Um, our focus as the post-op nurse is to maintain safety. So always looking at safety, and also to be identifying actual and potential problems. So what could go wrong? What are things that that I'm looking for? Also based on what happened in the pre-op assessment. You know, when I'm getting this patient, I'm going to get report from the OR nurse. So it's kind of like telephone, pre-op to OR to post-op. Um, and so there are policies and procedures and protocols for how often you're going to assess and monitor based on types of surgery and ages and all those types of things. But we're going to talk sort of in general terms of what you're going to be assessing for and all that. And so this particular PowerPoint talks about phase 1 and phase 2. In terms of phase 1 is where you're kind of looking still, what do I want to say, like assessing the patient, watching them for a long time. Phase 2 is they're like ready to go home, because sometimes recovery takes longer for some surgeries than others. And so the safety is the determinant of the level of care of what's going to happen and where they're going to go. And so when you talk about the first phase, when you're coming to the PACU, that's the initial recovery there. Again, the SBAR handoff report, ABCs, airway, breathing, circulation, right? You're always watching, you're looking not only at the monitors, but you're looking at your patient. What does your patient look like? Do they look and sound, and is everything, you know, looking like what it should look like? What is their level of consciousness based on the anesthesia? Is that where it's supposed to be? Some people have a harder time coming out of anesthesia than others. And so this is just a list of different equipment, that you should have there. You don't need to know that. That's not that important at this point. And then we have a different client for our case study for post-op. And so we have a 64-year-old white female who had a subtotal gastrectomy for a mass found in her stomach. So basically what they did is they took out part of her stomach that had this mass. And so she's taken to the PACU immediately following surgery. She's extubated, so she had a tube in to help her breathe and give her the anesthesia. So they took that tube out, and so she's starting to wake up from surgery. So think about, what are you on alert for? What is it that you're wanting to see from her? What are you assessing during this initial period when she's coming to you in PACU? And so the anesthesia care provider provides a report to me, the receiving RN, or to you, the receiving RN, and what should they be telling you? So they're going to write a report, but I don't have time right now and the report isn't written necessarily. So what do I want to know? I want to know what type of anesthesia they gave, if they had to give any like antiemetics. I want to know, depending on the type of anesthesia that they've given, when does the anesthesiologist expect them to start to be waking up? Is there anything in anesthesia history that I, as the nurse, should know about that I haven't heard about? If there were any problems during the surgery, that would be good to know about. If there's problems intubating, because then they're going to have a sore throat anyway because of the intubation. But if there were other issues, I'd want to be on alert for that. ABCs again. And so I want to know, you know, the general information, what was in report as I'm getting report, anything in the patient history that I need to be aware of. Because remember, I'm post-op now. I didn't necessarily get all of this information or have had time to look through the history and physical. So I also want to know during the operation, the medications, right? Any other medications, blood loss, what IV do they have running at what rate? What was the urine output? And then also, were there any kind of things we just talked about? Were there any reactions or unexpected things that happened? Were the vitals stable the whole time? Did they do any lab testing that I need to know about? And so the report that we get from the anesthesia care provider, she received general anesthesia. They extubated her. She's got D5.2 normal saline going at 100 mLs per hour, and the urinary catheters draining clear, pale yellow urine. That sounds pretty good. So far, so good. And then she does have an NG tube in because they took out part of her stomach, so they're going to want to be draining any fluid that's accumulating in there. Her vital signs are stable. The abdominal dressing where they perform where the incision is clean and dry. And she's drowsy, but we can arouse her. She will wake up. So again, these things are good. I would expect pale green fluid at this point. And so what other post-op assessments should you perform on arrival to the PACU? What are you thinking that you want to do now that you've gotten report and based on the type of surgery and things that you're looking at, what is it that you want to focus on? So of course, back to our ABCs, looking at her airway, doing a focused respiratory. This is where your focused assessments come in, your focused breathing, your focused perfusion, circulation. What are the vital signs? Check the cap refill. The peripheral pulses, what's her pulse ox? Does she need any supplemental oxygen? It doesn't say she's on any oxygen, but based on my assessment, does she need any oxygen? So our ABCs first. And then I want to know her level of consciousness. She had general anesthesia. She is arousable, so that's good. But when she's arousable, is she, able to, does she know where she is, who she is? This is your focused neurological assessment. You can check the DTRs, you can check grips, you can check her PERLA, those types of things. She's not getting up to go to the bathroom yet. She's got the Foley in, and so we want to, maintain the IV, check the IV site. She's come, it started in pre-op and then she went through surgery and then now she's in post-op. Is it still patent? Does it look secure? Was there blood loss? What is her output? And we're also tracking not only the urine, but the nasogastric output, because we're also going to look at the fluid balance there with the intake and output. Now she had stomach on her surgery. So we're going to want to, of course, do a GI abdominal focus assessment. Does she have bowel sounds? The NG, we want to make sure that it's where it's supposed to be. And is the order to have it to suction? Is it to be clamped off? If it's to suction, is it intermittent suction? Is it continuous suction? And we'll talk about that in skills lab when we get to NG tubes, because NG tubes are not just for feeding. They can have stuff, you use NGs to put things in and to take fluid out. Is there any nausea? And of course, integument, we want to, check the dressing site. Is she having pain, incisional or other pain? Are there any labs or diagnostics that they want? Do they want another CBC or something after the surgery? So we want to check so that we can get lab, or if X-ray or somebody would need to be there so that we could contact them. And then we need to be thinking about complications that could happen. So our priority action should focus on preventing post-op complications. So what is she at risk for following a subtotal gastrectomy? Now, we haven't talked about that type of surgery. But with any surgery, we're going to have some of the similar types of complications or potential for that. To think in terms of the anesthesia. What does the anesthesia do to the gastrointestinal system? What does, she was intubated, she had general anesthesia. Are there any complications that could happen as a result of that? And so this is, I think I can make that a little bit. Nope, can't make that one bigger, sorry. So I like this diagram because it talks about the different systems and where you could potentially have complications. So we talked about, let's talk respiratory first because she was intubated. So she could have potentially aspirated. Anything having to do with atelectasis, where the alveoli are going to collapse and not be able to aerate, is going to cause hypoxemia. She could potentially have an infection. And then we talked about perfusion. So do they have a history? This is a different client. I don't know. Do they have a history of hypertension or hypotension? We're looking for the VTEs. Might there be any dysrhythmias? They didn't say that there was any blood loss for this surgery. But if you think in terms of like a C-section, over 1,000 mLs would be considered a hemorrhage. And we had a client, I want to say it was over 2,800 mLs of blood loss. And so then what are we looking at in terms of that? Could there be more bleeding happening? Where are we looking? Oops, sorry. Where are we looking for the bleeding? What are we going to be? Are we going to do labs? Do they want an H&H? And then we talked about level of consciousness. So, and their temperature, because that can also tell us about their status as well. Are they going to be running a fever? Some people, again, it takes a while to come out of anesthesia. They can be awake, but maybe not as alert as they should be, just because it takes a while. Or sometimes clients can even be a little combative just because they're coming out of the anesthesia. The integument, right? The incision site, does that look clean? Now hers would not be on the leg, it would be on her abdomen, but we're still looking for the same thing. Are there signs and symptoms of infection? Is it pulling apart? Is Rita, is it redness, edema, ecchymosis? Are the sutures or staples or whatever well approximated, that type of thing. She has the Foley in right now. I'm saying she, and I can't even remember. I think it was a guy. Sorry, a gentleman. The client could have urinary retention as a result of the anesthesia. So we want to make sure that the intake and output, we've got fluids going at 100 mLs an hour. So we want to make sure that they're urinating at least 30 mLs every hour or more. If they're having 100 coming in, we want to make sure that output is good. And then for our particular client with the gastrectomy, so the anesthesia is going to, can potentially cause delayed gastric emptying. It can cause what's called a paralytic ileus, where nothing's moving through the intestine just kind of stops moving. And then sometimes there can be a lot of nausea and vomiting. And so we have this client now who has an incision on their abdomen and they feel like they have to throw up. And so we're going to have to get a pillow or something to help splint, to help them do their cough and deep breathing, and to put a little counter pressure on the abdomen if they have to cough or throw up. And because there's delayed gastric emptying, then there can also be distension and increase in gas. For our C-section clients, we give not only colace, but we give milk of magnesia to help to soften the stools and to have sort of a laxative effect, to not put extra pressure on the incision. So again, more complication, list of going through the systems again. You can have bronchospasms, hypoventilation. Sometimes the anesthesia is kind of heavy, and so their respiratory rate's pretty low. So we want to keep trying to wake them, wake them up. We're going to be doing focused respiratory, so we're listening to the lung sounds. If we hear a lot of crackles that don't go away, or if we don't hear breath sounds, those are things that we need to immediately report to the physician. And then this just kind of shows you could get, it keeps saying airway obstruction. Well, from what? The tongue. If they're not awake and alert, then the tongue can actually occlude the airway. So we want to be looking for that as well, and to position the patient appropriately. And so then this is showing how the atelectasis can occur, the alveoli. We've talked about the air sacs, the alveoli that expand, where you have the gas exchange. And so it's there. And then you can get from the anesthesia, you can have mucus plugs that accumulate, and then you get a mucus plug so that then the alveoli aren't aren't aerating, and so then that particular part of the lung then collapses, and you won't hear breath sounds. And so what interventions, what things can we do to prevent respiratory complications? A lot of the things that, positioning always, we'll generally have the client be on the side, in a side position. You can do lateral recovery position. And then once they're awake and conscious, then we can put them supine and elevate the head of the bed about 30 to 45 degrees, depending. If they need oxygen, the cough and deep breathing, incentive spirometer, so important. We talk about teaching incentive spirometry, but then sometimes I think we forget to remind the client. So I think if in post-op we can do a good job of educating them, then that will help them continue to use their incentive spirometer. We're going to continue to change their position, get them up walking, make sure their pain's okay, keep their hydration going. We could do some chest PT. I have not a whole lot necessarily. Do we need that? I'd probably call in respiratory therapy and consult and do some collaboration with them and see what their thoughts are. This would be splinting with the pillow here. You see that a lot with cardiac patients. They'll get their heart pillow. The pillow's in the shape of a heart, actually, which I always thought was kind of clever. Things at risk for cardiovascular perfusion wise, right? Hypotension, hypertension, potential dysrhythmias, the venous thromboembolus, and fainting, like feeling dizzy and fainting. So we want them to dangle right at the bedside. We want to get them up, but we want to make sure that they're safe. And then fluids and electrolytes. They've got this fluid going, but maybe they're not urinating as much due to anesthesia. So we wanted to keep a look at that. If they have decreased potassium, that can happen. You can get acid-base imbalances, which we're not going to address at this time right now, but that can happen. And so a lot of times you'll see they'll add potassium to the IV fluid for the electrolyte imbalances. So what are interventions we can perform as the nurse to prevent any cardiovascular fluid electrolyte complications? Excuse me, again, we've kind of covered it. We're going to do our focused assessments. So monitoring the vital signs, if they have looking at the strip, making sure they have adequate fluid replacement, not too much, not too little, and then looking for bleeding, seeing if there's any surgical site bleeding. That will help as well. And then always intake and output, any lab results. If we do new labs, making sure checking that IV is still patent and not infiltrated. And there's our early ambulation, monitoring for the orthostatic blood pressure and slow changes in body position. So that would be the dangle, and then just have them stand and then be with them. Make sure that they know to call you if they need to get up. To change position, or if it's time to get them up, if we take out the Foley and they need to urinate. Sometimes we'll use a bedpan or a urinal before we get them up to ambulate, because we want to make sure that they're not still under the influence of the anesthesia and going to just faint on us. Looking at the neurologic, psychologic, so emergence delirium, where they're coming out of the anesthesia and they really don't know what's going on. That can sometimes be slightly combative or more than slightly combative. Sometimes it doesn't happen right away. Sometimes there's a delayed response. So you're always kind of keeping that in the back of your mind. Post-op cognitive dysfunction, or like an alcohol or drug withdrawal delirium, if they were taking substances or taking, not letting us know about them, they could have those complications. So we should be kind of looking for those. And then to prevent neuropsychological complications, again, focused assessments, monitoring the oxygen levels, because if they're not getting enough oxygen, maybe we need to give them some oxygen, and that will help keep the pain management, keep the pain control good. Any protocols for alcohol withdrawal or any reversal agents that need to be given, like Narcan or something, or any other reversal agents. pain and discomfort. So there's physiological and psychological factors. You're always doing your pain assessment, and their pain is what they say it is. I always want to know when the last dose of pain medication is that they got. Did they get fentanyl in the OR? What time did they get that? That was IV. Okay, so when is that going to start wearing off? I want to be aware of what my orders are that I have currently. Am I giving Motrin, Tylenol? Am I giving Toradol? Can I give an opiate? Am I giving morphine IV? Like, what route am I using for my pain medication? And so what are some things that we can do to help MH, our client, prevent pain and discomfort? We're going to assess, we're going to anticipate, talk to them about breathing. Oh, look, they might have a PCA pump, right? We talked about that in skills lab. And so we would be making sure that they understand how to use that, using different levels of analgesia to help with the pain. And letting the client know that we're going to be asking them and for them to let us know if they're having pain, and then the non-pharmacological things that we could help them with, imagery or breathing techniques, things like that. So post-op complications regarding thermoregulation. So a lot of times the body's gone under a lot of stress, and so there might be hypothermia and shivering. There could potentially be a fever, and then there's always a possibility of malignant hyperthermia. Just because the client doesn't have a history in the family of that doesn't mean that they're not at risk for it, potentially. So you can use warming devices. You can give medications to help with the fever. You can do the dantrolene, the Dantrium for the malignant hyperthermia. And you have your case study that you did about that, what the signs and symptoms of that are. Asepsis, right? Your clean technique, coughing, deep breathing, those are all things that can help with that. GI complications, nausea, vomiting. So a lot of times we'll do IV push Zofran to help, potentially constipation. So we'll give the stool softeners and laxatives. You could have the ileus. We talked about that. And the hiccups. For some reason, people get the hiccups after GI surgery. That can be a side effect. I'm not sure why, but it can happen. So what are we going to do to prevent GI complications? Again, focused assessments, making sure we know what our orders are for medications that we can offer and give. Are we advancing their diet as tolerated? Are we going to go to clear liquids? Is there any other therapies that we can do? Making sure that they are hydrated. We're going to assess their bowel sounds. Are they hungry? If they're passing gas and they're hungry and they have bowel sounds, they're not nauseous, then maybe they could have a little something to eat or drink in PACU, and getting them up and moving, because that will help. And we see that a lot with the C-sections, right? We want them to get up and moving. They do have sequential compression devices, but we do want them up and moving around as soon as possible. You can have urinary complications in terms of retention, decreased output, oliguria, and then you also CAUTI, the catheter-associated urinary tract infection, is something to be on alert for. And so what are we going to do to prevent complications? So we're going to do focused urinary, monitor the output, making sure they're hydrated. So see how the hydration kind of also moves through everything? That's really important to have the fluids there. You want to remove the catheter as soon as it's no longer necessary. And there are protocols for when that will happen. Usually for a C-section, we're trying to do that within the first 12 hours, sooner if possible. Make sure they have normal positioning for elimination. We can also use a bladder scanner, like if they're not urinating. Say we've taken the Foley out and they're not urinating, we can get a bladder scan done, which we do. We can do that as nurses. We do that, and then we could do an intermittent or straight catheterization as needed to empty the bladder. And that's important after a C-section, because the bladder can impede the uterus from involuting, from contracting the way that it needs to contract to stop bleeding. And then surgical site infections, complications there. Not necessarily are we going to see it in the PACU, but for some reason it could get started there if we don't use our aseptic technique. But we also need to be vigilant about what does that wound look like. So is there, is it starting to swell? Is there fluid elimination, fluid accumulation? Are we seeing any blood that wasn't there? So if there's a dressing, we want to be marking it to see if there's more drainage that's happening that can indicate a problem. And so again, we're going to do, there's your COCA, color, consistency, amount. Does, when the client moves or changes position, does that put any undue stress on the wound that might potentially pull it apart? That's what dehiscence is. When dehiscence is where the incision starts to pull apart. Evisceration is where, like if it's an abdominal incision, like the intestines would start to come out of the opening where it would open and body parts come out. And so then we're thinking, okay, when are we going to be ready for discharge? When can we move from phase 1 to phase 2? And so there should be a written policy and procedure at the hospital, might be different in the hospital than ambulatory care, but there should be some type of criteria. And there should also be some parameters that have been set by anesthesiology and the physician. And usually the physician will come and see the client after the surgery. They might have to do another surgery and then come see you, but they will always, generally, in my experience, come back and talk to you. And then there's usually a standardized scoring system used with different criteria. And so the anesthesia has been discontinued. Are we returning back to normal function, normal neuro checks that we're doing? And then on the particular scale that they're using, the higher score indicates that they're ready to transfer or be discharged to that next phase of recovery or home. And so this is one of those systems. I've not seen these systems used. I don't know if any of the students that have been in C-sections, if they have seen these, but I want to say that's sort of more for a, well, it would be in an ambulatory setting, because would they be going home in a, where we're seeing it in C-sections, it would be, are they able to go from the OR and the PACU area and then move to the mother infant unit? So they would want to be making sure that a lot of these criteria, are met. So let's go, sorry. There we go. And so to come out of phase 1 and go into phase 2, are they awake or wherever they were at baseline, right? Their vital signs are good, no excess bleeding, their respiratory is good, their O2 is greater than 92, their pain is under control, everything's under control, we're like status quo, good. Then we can move to the next stage or end discharge. And so you're going to give your S-bar. And then phase 2 would occur in ambulatory surgery. It can occur also in the inpatient or intensive care area. And in this phase, it's nursing care that's focusing on preparation for care in the home. And so we're doing an extended observation. So this would be for us in the hospital when we have the C-section client. This would be when they come to us. They've already been in PACU, and now they're coming to us, and we're going to keep them for probably 2 days and do a lot of teaching with them and making sure that that things are stable. A lot of the moms that we're seeing are like med-surg patients. They have preeclampsia, they have hypertension, they have diabetes, they had a lot of blood loss. So there are different medications or different things that we need to be aware of and help them with. And then they just had surgery, but they also have this baby that they have to take care of. And so trying to work with them on that transition and what support systems do they have available to them. And so so extended observation, nursing care focus, right? We're preparing the patient for self-care at home. And so in ambulatory care settings, same-day surgeries, so they can also, sometimes they might have to go to extended observation depending on how things went with the surgery. And then ambulatory care, looking at they haven't had opioids in the past 30 minutes. They have to have voided before they can go home. We want to make sure that they void, they can ambulate. So this would be discharge criteria. So this would be that they would be able to go home. And so they have to have somebody there that can drive them home, and that they have the written discharge instructions. There might be prescriptions that they can repeat back to you what kind of care they're going to have to do when their return appointment is to see the physician after surgery. And so those would be the criteria. So one of the things that would keep you there is if they keep the client there is if they hadn't voided. Utilize the teach back method for your discharge teaching. So often I just see the nurses hand pamphlets or hand paperwork to the client. And especially if the client is multiparous, if this isn't their first pregnancy, then I think sometimes or their first baby, I think we just sort of take it for granted they know what to do. But things change over the years. Evidence-based practice changes. And so it's always good to really go back over and make sure they understand their self-care and the care of the baby as well. And that I would include their partner, their support person in that. Do they understand that as well? Do they understand the medications that they're taking, what they can and shouldn't take with those medications? Are there any activities that are prohibited? So for example, with a C-section, we don't want the mother lifting over 10 pounds of weight because of the incision. We don't want, they usually will do at the 6-week postpartum check. They don't want the woman having intercourse prior to the 6 weeks. And then is there any dietary restrictions or modifications? Y'all did that on your postpartum assessment, right? You talked about increasing fiber and fluids and moving around, those types of things. Or is there anything that they shouldn't be eating? And then when to call the doctor, that they know when their return appointment, their postpartum appointment is. Did they know when the baby's follow up with the physician, which is usually 2 days? Any resources that they might need, and then ask them what questions they have. Encourage them to write down their questions, or as we get closer to discharge, encourage them to write down any questions that they think of so that they can ask the doctor or the nurse as well. And reasons that you would want to seek help after discharge, that you'd want to call the doctor. So if the pain isn't relieved, if you have questions about the medications, if there's any change in the wound, drainage, bleeding, the stitches come apart, or if they have like drains, if there's more drainage or the drainage changes or smells or something, and then if there's a fever, those would be reasons to call the doctor. And so now our client is 2 days into her post-op recovery after her partial subtotal gastrectomy. She's alert and oriented, so that's all good. Her vital signs, I don't know. What do you think of those? Blood pressure, okay. Heart rate, okay. Respiratory rate, temp is a little bit high, definitely over 100. And so what do you think? What do you think about that? What are we thinking? 93% on room air. I mean, it's above 92%. And we're doing our focused respiratory. And so we hear crackles in her bilateral lower lobe. So both lower lobes of her lungs have crackles. So I don't know, temperature, the O2 sat's a little low. We have crackles. What kind of complication are we thinking? Something respiratory, something where we're not necessarily moving air, maybe. Skin is warm and dry. Bowel sounds. Oh, bowel sounds are absent in all 4 quadrants. That's not good. And her abdomen is tender and slightly distended. She does have her NG tube. It's connected to intermittent low suction, and it's draining brownish green drainage. Well, now I'm kind of concerned because we have sounds like something respiratory and something GI going on. So the surgical wound margins are approximated. There's no redness, and the clean dressing is covering the wound. So the wound seems to be doing okay, which is good. So what do you think is occurring? What complications could be potentially occurring? And what assessment data helped you to make that decision? I think we kind of went over that with the respiratory assessment and the GI assessment specifically. So, are we thinking respiratory wise? What are we thinking? Are we thinking pneumonia, atelectasis? What might be infection? Um, what are we thinking in terms of the GI motility? Because she's not really moving anything. Let's go back and take a look at that one. Bowel sound, there's no bowel sounds, and her abdomen is tender and slightly distended. So, I don't know, maybe an ileus, like there's no movement in the intestines. That could be the problem. It's not our job to diagnose, but when we look at the symptoms, we can be thinking about those different things, and what are we as nurses going to do to help with those symptoms. And so when we look at complications, atelectasis is one of the main ones that you see, and you're gonna see a fever and crackles in the lung bases, and then a marginal, meaning a low O2 saturation. Um, but again, for pneumonia, you're gonna see fever and a low O2 sat and crackles in the lung bases. And oh gosh, dehydration, you could have the same thing. Wound infection, you could have a fever. Phlebitis, like redness, and urinary infection could also, phlebitis would be like um, working its way towards a VTE, but you can see fever in these things as well. So then, okay, what do we do? Well, we have to let the physician know, certainly. But what are some interventions that we can implement to address those potential complications? Is there anything what's going to give us the most bang for our buck that we potentially could do? And so we're going to tell the surgeon, the physician, these are the things that I'm seeing. The breathing is doing this. I hear crackles. There's a fever. And so then we're going to want to find out, we can do a chest x-ray. We could do a UA to rule out urinary tract infection. And you're going to, of course, use your S-bar to communicate to the surgeon. And so we can have her turn, cough, deep breathe, use her incentive spirometer, because that's going to help open the alveoli. We can increase her mobility, give her pain meds before using the spirometer or having her move around, and increase her fluid intake. So 5 days later, so they didn't really address the bowel that much. They went more for the atelectasis. I think it's just an ileus. And so basically you do rest and increase the fluids, and that hopefully will help and get her up moving and doing the deep breathing and all that. So it's 5 days after surgery. So it's 3 days later from where we just were, and she's being discharged. And she and her husband are anxious that she's being discharged so soon after serious surgery. And so what is your priority for the couple? I mean, 5 days is a long time in surgical stay. But that's the couple's perception, is that it's so soon after the surgery. And so what are your priorities? What are some things that you're going to want to assess for or ask them, or resources that you're going to want to have available for them? And so then when we look to discharge criteria now, when they're coming out of phase 2 and going home, making sure that the pain is managed, the surgical site is intact, they're hemodynamically stable, their hydration status, they voided, they can ambulate independently. And then I think important one is the emotional status and significant other interactions. Because if the significant other is there, we want to include them as much as possible. And also the emotional status, make sure that they feel safe and they're getting their needs met and their questions answered. So, I mean, you could potentially do social service consult, you could have clergy come in, different things like that to talk to them might be helpful. And then when we're talking about gerontological, considerations. They're just more at risk for like drug toxicity, for example, because they'll be on a lot of different medications, the polypharmacy, and things interact with each other. Mental status changes that happen, like they could have good mental status prior to going in, and then the anesthesia and having the change of environment and different things can affect their mental status, pain, and then of course respiratory function and decreased vascular function just kind of go along with aging population. And so now we have a couple practice questions. So the patient becomes restless and agitated in the post-anesthesia care unit as he begins to regain consciousness. Which action would the nurse take first? So we have a client that's kind of restless and agitated. What does that sound like? What did we talk about last semester in terms of the client who's feeling restless and agitated? And so would we turn them to the lateral position? Would we check their oxygen saturation? Would they reorient the patient, tell them surgery's over, give an ordered post-op pain medication? So the correct answer would be B, check the patient's oxygen saturation because they're restless and agitated. And we talked about how if you're not getting enough oxygen, that's how you feel sometimes. Like you feel like you can't catch your breath. And so we want to check their oxygen saturation and see where that is. And then while in the PACU, the patient's blood pressure drops. So when they started, it was 126/82, and now it's 106/78, which, I mean, that is a decrease. But it also now there's a pulse change that went from 70 and up to 94. And so that's kind of indicative of some things potentially. And so it sounds like we're giving oxygen first. And so after we put some oxygen on, what is the next, which action would the nurse take next? And so we have increased the rate of the IV fluids, notify the anesthesia care provider, perform neurovascular checks on the lower extremities, use a cardiac monitor to assess the patient's heart rhythm. If the blood pressure is dropping and the heart rate is increasing, we want to give fluids to help get the blood pressure back up and take the work off the heart a little bit. And so the answer would be to increase the rate of the IV fluids. And let's see, finally, I think this is the last question. The nurse is preparing to discharge a patient from the ambulatory surgery center following an inguinal hernia repair. The nurse delays the release of the patient upon discovering that the patient, so there's something, one of these answers is going to be a reason for us to keep the client in the center, to not let them go home. So is it that they had IV morphine 45 minutes ago? Is it that they have an oxygen saturation of 92%? Is it that they have not voided since before surgery? Or is it that they had an episode of vomiting 30 minutes ago? So what is going to make us keep them in the surgery center? I think your choices would probably be between B and C, the oxygen saturation of 92% and has not voided since before surgery. IV morphine 45 minutes ago, that would be okay. And then vomiting, that's not necessarily something that's going to keep them there. The oxygen saturation is 92%, which although is at the bottom of the limit, is still acceptable. But the fact that they haven't voided since before surgery, so they're getting ready to be discharged and they haven't voided yet, that's a problem. We need to investigate that further and maybe do a bladder scan, see if there's how much urine is in the bladder, are they retaining the urine? But that would be a reason to not let them go home, would be because they have not voided since before surgery. And so, and so that would conclude our post-op teaching PowerPoint. Things again to be on alert for, the key things for that are what are the complications by body system that you should be on alert for, looking at the respiratory and the cardiovascular, looking at the integument with the skin, urinary with the voiding. and looking at, but in terms of, systems, I think is the big thing to take away from that. And then what enables the client to be able to go home? Is it, what are the safety things? What do they have to have, you know, being able to do in order to go home? I think those would be your two key takeaways from that. And so again, I will stop sharing. And thank you very much. And let me know if you all have any questions.